Hello, my name is Reagan Stange. I'm a junior at Missouri State University where I study cell and molecular biology. Welcome to my poster presentation. I'd like to thank Jill Layman and Dr. Brooks for the opportunity to present about this study, in addition to my fellow student researchers and the participants who volunteered their time. Many studies have demonstrated that masks are effective at preventing the spread of infections, including COVID-19. Despite the advantages of masking, some have questioned whether wearing a mask can cause CO2 to build up in the body, causing harm to the one wearing a mask. A 2021 study even claimed to demonstrate that toxic levels of CO2 were continuously inhaled when wearing a mask, but that study was critically flawed in its methodology and was quickly retracted by its publisher. Our study aimed to provide a more accurate representation of the effects of wearing a surgical mask. We assessed ventilation, oxygenation, and vital signs using an anesthesia machine. In order to monitor ventilation, we measured the subject's end-tidal CO2. End-tidal CO2 monitoring emerged as the standard of care in anesthesia in 1986 for continuous monitoring of the level of CO2 in a patient's body. If an individual's end-tidal CO2 level increases, that indicates that the patient is retaining CO2. Over the course of the study, we had 71 adults and 49 children participate. We tracked their inspired CO2, end-tidal CO2, and respiratory rate with a nasal cannula attached to a side stream capnography unit on an anesthesia machine. We also tracked the participants' oxygen saturation and heart rate by using pulse oximetry. We recorded each of these variables once every minute. We had the participants breathe regularly while sitting for 5 minutes without a mask, and then for 15 minutes after donning a mask. As you can see in figure 1 here, we found that inspired CO2 levels rose from 3.30 before masking to 6.30 millimeters of mercury after masking in children, and from 3.09 to 4.57 in adults. Figure 5 shows the increase in end-tidal CO2 between the masked and unmasked periods. This increase was statistically significant, with an average elevation of 1.30 millimeters of mercury in adults and 1.36 in children, but the participants' end-tidal CO2 levels remained well within the normal range, whether masked or unmasked. Paired analysis of the 5-minute masked periods confirmed that the inspired CO2 and end-tidal CO2 levels remained steady for the 15 minutes that the participants were wearing a mask. Both levels did not continue to increase. This suggests that if the participants were monitored for a longer time, their end-tidal CO2 levels would not continue to rise. Figures 2, 3, and 4 show that respiratory rate, heart rate, and oxygen saturation remained unchanged in adults and children, whether they were wearing a mask or not, for the entire duration that we were recording vital signs. So the rise in inspired CO2 is consistent with what's expected after donning a surgical mask. There is a small mechanical dead space behind the mask where the fraction of CO2 in the air increases. However, the end-tidal CO2 increased by only 1.36 millimeters of mercury or less, which is clinically insignificant. It is also evident that masking did not have a physiologically significant impact on the participants, since their respiratory rate, oxygen saturation, and heart rate all remained unchanged. Surgical masks contain tiny pores that can minimize respiratory droplet transmission of diseases by trapping the droplets with electrostatic charge, but those pores are thousands of times larger than CO2 and oxygen molecules. That way, CO2 and oxygen are able to flow freely across the barrier that the mask provides. Based on our findings, we can confidently say that adults and children over age 2 may be encouraged to wear a mask without any concern of carbon dioxide retention or impaired oxygenation. Thank you for your time.